and I will take questions from the audience. Thank you so much for your attention, and I guess Stephanie will be managing the questions.
Yes, thank you so much, Dr. Paula. This is incredibly informative, and we do have a number of questions. So one of the participants asked, I have a periodic diagnosis of nested variant cells, non-muscle invasive. Is this small cell or something else? What is recommended for treatment?
So nested cell is another really, really rare variant of urothelial carcinoma. And, you know, we don't know the best management for these tumors. So right now, we manage them as urothelial carcinoma depending on what stage it is. So it's non-muscle invasive. These tumors are managed locally. And when they become invasive, sometimes they declare themselves and they transform. And it's not uncommon to have multiple cell types that are together. And really what we do is we take the most aggressive cell type and we treat that one if we know how to treat them, if the treatment is different than urothelial carcinoma. But unfortunately for nested variant, we treat it as urothelial carcinoma, but although we do know it behaves more aggressively.
Thank you. Okay. Are micropapillary tumors chemosensitive?
This is a great question, and this is a common issue that comes up. If somebody has muscle-invasive bladder cancer with micropapillary, do we give them chemotherapy? The argument is these may be more resistant to chemotherapy, and that these patients should go straight to cystectomy. But another argument that is made is that these patients often have lymph node metastases already, and they have a higher rate of spread. So wouldn't it be better to try to treat them systemically as metastatic disease initially with chemotherapy, and then do the cystectomy later? So some series have shown that that micropapillary may be more resistant to chemotherapy, but some series have shown that it may not be. So it's still controversial as to what the best management, especially for muscle invasive disease, where the treatment is remove the bladder and give chemotherapy or not give chemotherapy. The management is controversial, and that's why I didn't put it in my slide, because some retrospective reviews have shown that yes, these tumors are more resistant. But then some other retrospective reviews have shown that these tumors do better with chemotherapy and surgery than just with surgery alone. So, and again, these are small, so it's really hard. It's really hard to interpret it, because sometimes you need really, really large numbers to tell the differences between whether there's a benefit in adding a treatment or not. But I say until we know otherwise, I think it's appropriate to treat them with chemotherapy. And if they're muscle-invasive disease, with radical surgery afterwards.
Okay, thank you so much. I have a question. I think what this individual is asking is, how often is precise delivery of treatment, are the different types of drugs delivered precisely to cancer cells in these rarer forms of disease? I know that within all variants of, the common variants, when we have a specific genomic mutation, they can target specific things. Do they know enough about these rare cancers to be able to target therapies?
Not yet, no. And urothelial carcinoma, regular bladder cancer, just received the first targeted therapy approval by the FDA this year. So we're really just learning enough about bladder cancer, and that was an FGFR3 inhibitor that's now approved for urothelial carcinoma that has FGFR3 mutations or alterations. We don't know enough about how to target these rare tumors, rare histologies, or variants enough to treat them like a personalized approach, like by their mutation or by their genetics, yet. Some some tumor types we know enough to treat them by targeting the mutations. Bladder cancer, we just have the first approval this year, but for the rare variants, we do not yet.
Well, I think you did an amazing job of highlighting some of these challenges, particularly in really understanding some of these very rare variants of bladder cancer. What is your recommendation then for patients who have a diagnosis of one of these off the beaten path types of bladder cancer? Should they engage in a clinical trial? Is there a way, is there anybody that's doing any work to do a deeper dive collectively across the board, maybe a tumor registry or something that's looking at these different non-common variants of bladder cancer? Is there anything you can suggest to patients?
So I say it's always good that if you have a diagnosis that is uncommon, to get an opinion from a high volume academic center where the investigator or the doctor has experience with these rare tumors. And there are many investigators throughout the country that work in bladder cancer and are interested in rare bladder tumors and variant histologies, and are collecting tumors and are doing RNA sequencing on them, and in order to learn a little bit more about the biology of these rare tumors. So, find an investigator near you that can advise you on your management. And if it's not possible for you to travel, ask your doctor to find an investigator that they can talk to, run the case by, so at least your doctor engages an expert in your management if you can't travel there yourself. I think it's always better for you to go and get a second opinion from a high volume center if you can, because these tumors are rare and every case is different. So we can, I can only kind of give an overview of how they're generally managed. And for most urothelial carcinoma variants, they're generally managed as bladder cancers, just regular urothelial cancers. But for the pure histologies, these are managed differently. So I think it's important to kind of have another pair of eyes that has knowledge with these tumors to discuss your case. So number one, I favor going there, but if it's not possible to travel there, at least have your doctor engage an expert by contacting them, getting a review in the pathology. That's another thing too, is the pathology. Your tumor is being looked at under the microscope by a pathologist, and sometimes if the pathologist hasn't seen many of these rare tumors, they may not be as familiar in making the diagnosis. So when you get a second opinion, you often also get a pathology review by the pathologist in the academic center that can confirm or not confirm the diagnosis that was made of the rare tumor.
Great, thank you so much. Are there any particular tests that are used to diagnose the existence of micropapillary carcinoma? Or is it just the pathology that determines
so
that?
It's morphology. So what I mean by that is it's what it looks like under the microscope, and that's generally the way that it's doing. And there's some stains too, but generally it's by morphology. So again, it's subjective, and that's why the diagnosis of these tumors are increasing as pathologists are becoming more aware of this subtype and are diagnosing it more and more as they learn more as to how to do it.
Okay, great. I know you can't answer specific questions, but there is one that came in. What is your opinion about the potential use of enfortumab for rare forms of bladder cancer? It's my understanding it's pending at the FDA for approval for use with lung and bladder cancer. It's been diagnosed as a potential for my father's small cell bladder cancer if approved for rare forms. What is your opinion?
It's a great question. I think that's a really good question. So enfortumab vedotin is a new drug, It's a new drug that is showing promise in regular urothelial carcinoma bladder cancer. It's an antibody drug conjugate, and what it basically is, it's a fancy chemotherapy that is carried by an antibody specifically against a specific antigen that is nectin. When nectin is found in urothelial carcinoma, and over 90% of urothelial carcinomas, whether nectin, which is the antibody that target, is found in small cell bladder cancer, or whether it's found in adenocarcinoma or urachal, I don't know the answer to that. I mean, I think that we need to find out. I mean, how commonly is nectin expressed? And if it is, can we give this novel drug to non-urothelial carcinoma tumors? I mean, I think that's an excellent question, and I don't know the answer to that, and I think we need to find out, because once these therapies are approved for urothelial carcinoma, why not make it, especially if there's limited treatment options, if somebody tells you there's nothing else I can do for you, why not try something new and learn from it? So, of course, it shouldn't be done, it should be done ideally in the setting of a controlled setting of a clinical trial, but that's going to be tough. And I don't know if the company has any trials ongoing with variant histologies or rare tumors, but that's a terrific question. And, I think, you give the standard chemotherapy, and now we know that immunotherapy in combination with the chemotherapy is active for small cell. But, once that stops working, it would be ideal to try a novel therapy. And, if I guess the insurance approves it, or if there's a way of getting a novel therapy, I think it's reasonable to try something new. But really, it's important to know whether small cell has that antigen, and I don't know the answer to that.
Okay, thank you so much. In patients with mixed histology in their primary tumors, do metastases retain the same proportion of variant cells, or do the more aggressive cell types metastasize selectively?
Oh, these are really, really good questions, and I'm really impressed with how knowledgeable the audience is. So we don't know, but it looks like generally the more aggressive cell types that are resistant to the treatment that is being given are the ones that grow. It's often we get something called like a mixed response, like some tumors shrink and some tumors in other parts grow, and it's generally the more aggressive cell types that grow. And in general, bladder tumors are very mixed. So it's the more aggressive components that eventually become metastatic. So sometimes when you biopsy tumors, they no longer say urothelial carcinoma. All they'll say is like poorly differentiated carcinoma. They don't even say urothelial, and they'll say something like more consistent with urothelial carcinoma, because they know the patient had bladder cancer. But most of the time they de-differentiate so much because they're growing so quickly, they no longer hold the morphology or the appearance of the initial tumor.
Interesting. Well, thank you so much for that explanation. I have one more question. We have time for one more question. And the participant wanted to know if you were familiar with any links between bladder cancer and spina bifida, especially situations of reconstructed bladder in patients.
There has been some trials looking at specifically patients with like indwelling catheter and spinal cord injury, to kind of, these are retrospective just to see the incidence of bladder cancer. And some of these are inconclusive, and some of them say, yeah, it looks like there is a link with patients that are, paraplegic, or not specifically spina bifida, but that have like a spinal cord injury, and either catheterize themselves or have indwelling catheters, and patients that have had reconstructions too, like a ureter reimplanted, or certain surgeries within the urothelial tract. So there is a small retrospective association that has been reported, but inconsistently.
Well, thank you very much. This has been very enlightening, and I hope that for the people that have been on this webinar, they've really learned a lot about what's being done and what still needs to be done about rare forms of bladder cancer. They do exist. So I really do appreciate it. I'd like to again thank our sponsors, Estella Seattle Genetics, Bristol Myers Squibb, EMD Serono, Pfizer, Genentech, Janssen, Merck, and PhotoCure for their support